One of the presidents of Morehouse School of Medicine once said that all children should know their grandparents. I chose the name, as I said, this is my practice, and family first. Putting family first and then their health. So providing patients the health care that they need in a family fashion. My name is David Blake. I'm a family medicine physician. My practice is Family First Healthcare in Lithia Springs, Georgia. In family medicine, we're trying to practice preventive medicine, taking care of patients' disease processes and preventing them from having problems with those or even developing them in the first place. So my remote checkup helps to do just that by checking in on the patient in between visits. Typically, you see a patient once a year at minimum, and then depending upon their diseases, every 6 months or every 3 months. So there's always going to be a time frame when there's no direct contact between the physician and the patient, but you still need to know what's happening with their blood pressure readings and their blood sugar readings. And this is a way that they can be checked on remotely. And some of our older patients don't really have a lot of family members or friends calling them, talking with them. So now they develop that relationship because the navigator from my remote checkup calls that person consecutively. They don't go from one to another. It's always the same person. They develop a relationship and they get somebody calling them and looking in on them. The patients actually enjoy the app because one, they can contact the office. No matter how many telephone lines, how many people you have working them, there's always gonna be somebody that has to wait. So this is a way that the patients can contact the office after hours, even during the busy office hour days, and get their information to me as necessary. If there's a problem, it gets brought to my attention and I can adjust their medication, advise them to come in, or get them to where they may need to be. I have patients that are Spanish speaking. So now in the office, I do speak Spanish, but the rest of my staff does not. But we can get them a navigator who can speak to them in their native language, and they can more comfortably communicate their needs to the office. Some of my older patients, when they come back in for their first visit of the year, they have no knowledge of my remote checkup. So I get a chance to explain that to them. I let them know that that's now part of our practice. It's a means for me to keep up with them. And in years past, I had to give them pieces of paper to check their blood sugars on and write it down and write their blood pressures down.
I was just writing down everything, and sometimes I'll forget to have a pencil in my hand when I finish my blood pressure, or I'll forget what it was, or I used to take pictures of it with my phone, then my phone will lock out, so it's like, golly. But when I got the device, it made it easier, is because the results go straight to the doctor's office or to whoever's watching it, and it goes to the doctor. So, yeah, I'm very pleased with that. I'm glad that Dr. Blake chose my remote checkup. It has really saved me and my mind, so now I don't have to worry about writing down anything. You get just what you want, and I got just what I want.
My remote checkup is physician-run, so it's somebody who understands the process of the medical office and taking care of patients. And my billings personnel, they're supervising the daily records anyway through the EHR, so they're able to see if there's anything going on that should not be. And so far, there's been no conflicts, no errors, and everybody has been happy with the process. Unless you really want to commit dedicated staff members to enrolling the patient, asking the questions, and then documenting the billing procedure, I found it has worked better to go ahead and let the My Remote Checkup personnel handle that. They're skilled in it. They have been doing it prior to my knowledge of the program. They know the codes to use. They know which billers will and will not allow it to be used. And therefore, they can go ahead and get the bills cleanly through and then turn around and do the reimbursement and reconciliations each month. And I have not thus far had any issues with that. And getting used to using the app myself, so far it has been fine. I have an opportunity to go into the app. I can find patients. I can see what their escalations are. I can see what their recent readings have been, and can communicate back with the patient directly from the app. That way it's not disclosing my personal information after hours, and they can still get the follow-up that they need in a timely fashion. Again, I'm Dr. David Blake, Medical Director of Family First Healthcare. I can be reached at 770-948-5400.
Welcome you all viewers to this today's remote diabetes management webinar. I am Santosh Karande, digital health consultant at Health Wealth Safe. I welcome today our honorable guest, Dr. Bantwal Baliga, MD. Originally, he is from India, trained at Kasturba Medical College, Manipal, moved to UK, training in diabetes and endocrinology, received MRCP degree from Royal College of Physicians, London, moved to Little Rock, Arkansas, then moved to New York, Mount Sinai School of Medicine, where he was the director of diabetes program. Now he is practicing as an endocrinologist at Columbus, Georgia, Opelika, Alabama, and Athens, Georgia. Today we are going to talk about obesity and diabetes, their newer medicines in treatment, and their health lifestyle and the healthy diet. Today here is the Dr. Bantwal Baliga. Hello, doctor.
Thank you, Santosh.
Yes. How are you doing today?
I'm doing fine. Thank you.
Yeah.
Thank you for a wonderful introduction.
Yes, sir.
Yes, so I'm excited to be here because what we are going to talk today is going to be amazing, right? Because we are in the midst of this epidemic of diabetes and obesity. So somebody coined the term diabesity,
Diabetes,
combining together.
yes,
So
yes.
because this has become a real health crisis, people are struggling, and a lot of money is being spent on this disease state. And there's a lot of misinformation out there. But as a physician, as we belong to this health, wealth, safe group and all, our job is to educate the patients and start the dialogue. So thank you for inviting me, sir.
You're welcome, doctor.
Yes.
Dr. Baliga. Let's talk about how you'll define the obesity.
Okay, so what we do is we look at World Health Organization definition. So that's the gold standard. Okay, so according to the WHO, overweight and obesity, it says it's abnormal or excessive fat accumulation that presents as a risk to health. See, that's the thing.
Yes.
It is not just a cosmetic, right? So what are the health implications of this disease process, right? So there are some definitions because we always look at the numbers, okay? One of the easiest way to do is look at the BMI, okay, body mass index. BMI of more than 25 is considered as overweight. Then BMI of over 30 is considered as obese. You can also look at the waist-hip ratio. Okay, if the waist-hip ratio is more than 0.9 for men and 0.85 for women, they're considered as obese. So those are the definitions. So.
Let's talk about how do you measure the diabetes and obesity?
Obesity, yeah.
Yes.
So again, we look at the WHO recommendation, right? Again, we look at the BMI. So a BMI of less than 18.5 is actually considered as underweight. What is the ideal BMI? Ideal BMI is about 18.5 to 24.9. Okay. Once the BMI goes above 25, then now we are considered as overweight. Okay. When the BMI goes more than 30, now we are in the obese category, right? Now, but again, there is some allowance that has to be made for Asians like us, right? Because we are a little bit smaller build compared to our Caucasian colleagues. So that's why the cutoff point is a little bit less. The ideal weight for Asians is BMI of 18.5 to 23. And overweight is when they go about 27 point, about 23 to 27.5 is considered as overweight in Asians, and more than 27.5 is obesity for Asians. Or you can look at the waist-hip ratio, right? You have a tape measure, you can measure the waist and the hip, look at the ratio. And again, the cutoff point is 0.9 for men and 0.85 for women. So.
Okay. Then how we'll talk about the classification of obesity and their health implications in the patients.
Correct. So that's very important, right? As I mentioned, it's not just the cosmetics. Obesity, if you have obesity, it's like you go to a downtown, you see a bad person roaming around, you bet there are other bad persons around that person.
Yes.
So that's why when we look at obesity, so we look at what are the other things that's going around, right? So first thing is you look at the classification, right? There are like three categories, class 1, class 2, and class 3. Class 1 is when the BMI is more than 30 but less than 35. Class 2 is 35 to 40. Class 3 is more than 40, right? So now we know that obesity can increase the risk factor for several diseases. For example, you could bet somebody walks into your office with obesity, they're likely to have high blood pressure.
Oh.
They're likely to have high cholesterol.
Oh.
They're more than likely to have a type 2 diabetes, pre-diabetes, insulin resistance, and cardiovascular disease. See, that's odd. We are, in a way, it's a blessing that when they walk into my office, when they see that they're obese, I can look for all these risk factors, right? They are more likely to have asthma and sleep apnea. And remember, sleep apnea is not an innocent disease, right? People can die in their sleep.
Oh.
So that's why it's very important to look at all these things. Osteoarthritis, they will have knee joint pain because the knee joints cannot take up so much weight. So they develop early osteoarthritis. And there's some data showing that obese people are more likely to have accidents, motor vehicle accidents. They can have a fall and break a bone.
Oh.
They can have cancers. See? Now, they can also have gallstone disease, cholecystitis, gallbladder disease. So, pancreatitis. So, as you can see, one by one, you see the health complications.
Sleep apnea is, I think every other patient has a sleep apnea. What do you say?
No, I wouldn't say every other. But yes, a lot of patients who are overweight. And especially, you look at a person who has a short neck and who has a significant visceral adiposity and they're obese. And we ask them, how do you sleep? And usually the partners say, oh, he snores.
Yeah,
she snores.
because
we stop
if
breathing.
you ask patient,
yes, I get up in the middle of the night 3 to 4 times to pass water. So those are all manifestations of sleep apnea. So whenever we discuss, we send them to sleep lab. So
then how common is obesity in the patient?
Yes, so again, it's staggering, because if you look at our whole generation, we are richer, okay? We have big refrigerators at home. We go to Walmart, we go to Sam's Club, and we fill our cart with all this bad food, right?
Yes.
So the food is cheap compared to other countries. In the United States, food is very cheap, right?
Yes.
So that's why we see even younger children. We used to see more type 1 diabetes in younger children, but nowadays we see type 2 diabetes in younger children because they are getting more obese. And they're developing class 1, class 2, class 3 obesities. So the recent data, as of 2022, 650 million adults, they are obese. And more than 1 billion people all over the world, they are obese.
Oh.
Could you
That's
imagine
a
that?
big number,
340 millions with the teens. So that's the thing, now we have this enormous number of persons with obesity. Now we know that what's going to happen next. This is a calamity waiting to happen.
Number is increasing.
It's increasing.
It's increasing like anything.
That's why, the problem is we don't have enough resources to battle this epidemic. And for example, we are not producing enough endocrinologists. That's why
we don't have.
That's why we have to work as a team. It takes a village, right? That's why we want primary care doctors to step in, family practitioners, endocrinologists, dietitians, diabetes educators, cardiologists.
Correct.
So it's a group effort. So we have to sort of help our patients to address this disease.
Because nowadays, as you said, endocrinologists are very less in the country.
Yes.
And getting appointments again difficult.
They have to wait till like
very
6
hard
months
to
and a
get
year.
Appointment.
That's the reason,
3 months,
I travel
5
all
months.
over.
Yes.
Yes, right?
Really, doctor.
Yes,
really,
yes,
you are
yes.
helping the community.
Yes.
Thank you for that.
Yes, that helps. So.
Yes. Now we'll talk about, doctor, like diabetes and obesity. Most of the patients, they have it.
Correct.
How it caused, like.
Yes. So how does it start? That's a very interesting thing.
Yeah.
So diabetes and obesity, we consider or we call them as multifactorial diseases. It's not one single cause.
Correct.
So usually there is a genetic predisposition, and on top of that, your lifestyle, how you brought up in your early life stage, what's your diet, what's your activity level, what kind of food you're eating, and how is your family members. And that's also important. As a family, we should eat better if one of us is obese or overweight. You can't expect one person to diet where others splurge on everything they can eat, right?
Correct.
So that's why usually there's some kind of environmental trigger that turns the whole metabolic process. Then people develop pre-diabetes and diabetes. So type 1 diabetes is mostly genetic, right? So
Genetic,
there's a genetic component. We used to call it juvenile diabetes. Nowadays we call it type 1 diabetes, where they do not have any insulin at all. They need insulin for survival. And it's the second most common childhood illness. And the triggers can include a cold weather, exposure to viruses, being a Caucasian, and there's some question about is the diet that we feed to our infants is like a cow's milk. Is it going to trigger some autoimmune response? That's why when you see type 1 diabetes, it usually happens in winter months, more common in European countries where it's cold.
Okay.
So as opposed to type 2 diabetes, and type 2 diabetes happens every day. Everywhere. Right? So typically it develops later in life. And nowadays we see children developing type 2 diabetes. It's crazy. People aged 8 or 9 or 10, they come to me and they have got a lot of weight issues and now they become pre-diabetic. Then they develop type 2 diabetes as opposed to type 1 diabetes. So again, there are two risk factors. One is family history and genetics. So we're going to talk about it in much more detail.
Okay. Then what about the obesity? Obesity can cause type 2 diabetes?
Yes. So what's the connection, right? Remember I told you, they're almost the same. It's like the same spectrum.
Okay.
You start with obesity, then you keep on developing diabetes and cardiovascular disease. So again, there are two main risk factors for type 2 diabetes. One is obesity and family history. And this is the natural history. Now, this is a very important cartoon. Okay. So what it does say, it says genetic susceptibility, which is very important. Then the environmental factors. For example, we talked about the nutrition, physical activity, sedentary behavior. I know that's one of the things. Our kids, they are on the sofa. Instead of playing outside, using the basketball hoop, they are on the sofa doing the computer games.
And mobile.
So that's the worst thing they can do. So as you can see, this problem starts very early in your life stage, in your teens. Then you develop insulin resistance, then you develop pre-diabetes, then you develop diabetes, then you develop cardiovascular disease. And during this whole process, you start having problems. For example, atherosclerosis, right, starts in your teens. So there's something called fatty streaks. We have seen aorta of young children who had died in motor vehicle accident. When you look at their aorta, there are already fatty streaks at such a young age. So we should not wait too long until we are at 30s and 40s to make a diagnosis. We should intervene very early. Because what happens, you develop atherosclerosis, you develop hypertension, your blood sugar starts going up. Then what happens, you develop diabetes. Once you develop diabetes, what happens? You're going to damage your eyes, your kidneys, your feet.
Correct.
What you call as retinopathy, nephropathy, neuropathy. And if diabetes is not well controlled, then you end up with blindness. You can develop an end-stage renal disease. You go on a dialysis machine. Then you can have amputation. Not to mention about heart attacks, strokes, and sudden cardiac death.
Even amputation too.
Yes. So this is the thing, because this is a terrible disease. But at the same time, if we intervene very early in life stage, recognize the future health implications now, rather than wait until something bad happens. Because once you develop diabetes, once you develop severe diabetes, once you start losing your organs, then you live with that deficit. You'll never be back to normal. So prevention is the key. That's why we need more education, right? We have to give more support to the community. We have to make sure that patients have access to the medications. So that's another thing, all these medications are very expensive.
Yes.
Right? So many of them cannot even afford.
But who don't have diabetic at all or no genetic diabetic, that time, like how they have to be preventive.
Yes. So
anybody can have a diabetic if they don't take care of themselves in the beginning, or a diet or anything.
Right.
In a day-to-day life activities and all that.
Correct. That's the best thing, right? Rather than wait to become diabetic and develop complication, then spend enormous amount of money.
Before you take care of it.
We can do simple thing which doesn't even cost you money.
Correct.
Exercise.
Yes.
You go for a walk.
Yes.
You go for a jog. You play basketball. You go for a swimming.
And
right?
we can
Doesn't cost you much.
Yes.
Right? Eating healthy.
Yes.
Eating healthy costs a little bit because when you go to the superstore, bad food is very cheap.
Yes. Always.
Healthy food
And
is
people
very
go for
expensive.
that,
But
yeah.
if you cook at home, bring fresh green vegetables, okay, cook in the presence of water, right? And eat fish, okay, chicken, right? And cut down on carbohydrates like the rice, pasta, bread, potatoes. They all taste good, but you have to keep smaller
everything
portions.
smaller
So,
portions.
yeah, we're going to talk about the diet a little
Yes.
bit down the road.
Yes.
So.
Okay. And what about you will talk about the obesity?
Yes, so-
What causes the obesity?
Yes, again, so if you move forward, so these are all the causes of obesity. We discussed again, so mostly it's what you eat, what kind of exercise you do, right? If you're a couch potato, if you sleep a lot,
Yes.
right? But there is something, sometimes if you do not have a good sleep, they recommend that 6 to 7 hours of sleep a day. Some people are insomniacs. They are more likely to develop diabetes and obesity. So, then social determinants, cultural, economic, right? Lack of health care, peer pressure, and genetics. You can't do anything. You can't return your genes, right? You
Yes.
just live with it, right?
You can't do anything.
But certain illnesses and medications, for example, somebody who is depressed, who is having a bipolar disorder, they're on all these psychotropic drugs. Unfortunately, some of these drugs can make them very, very insulin resistant. So then they gain weight, they develop tummy fat, visceral adiposity. Then they develop prediabetes, diabetes, and cardiovascular disease. Some people who are on prednisone, the steroids, for some rheumatological disorder or a cancer or something, that causes more insulin resistance and develop diabetes. And nowadays we see patients with COVID, post-COVID, their diabetes can get worse or they can develop
They gain the
diabetes.
weight as well, yeah.
Yes, so this way, the things are, with COVID we are still learning. So, yes.
Yes. And what about you'll talk about the dangers of the
Yes.
being
That's a very
obese
important
and
question, right?
diabetes.
Yeah, because when we talk about obesity, it's not just a cosmetic, right? We talk about pear shape and apple shape. Okay, let's say if you have a significant visceral adiposity, you look like an apple. So that means you have underlying insulin resistance syndrome, and you have metabolic syndrome. Okay, that means you're going to develop diabetes. If you have a pear shape where you have a small midriff and a little bit extra fat around the buttocks, that's a good shape, right? So that's why apple versus pear shape. So the thing is, when we know, as I mentioned, you see a bad person, like here, it is the obesity, what we call as visceral adiposity. You can imagine fat in the omentum, in the tummy, right? As a root cause of all the evil. And from here, you develop prediabetes, you develop diabetes, you can have osteoarthritis, sleep apnea, we talked about it.
Yes.
Vascular insufficiency, that's a peripheral vascular disease, high cholesterol, high blood pressure, asthma, fatty liver, right?
That cause, okay.
Yes, and more thrombotic events, and some skin conditions, inflammation, right? It's not like a superficial inflammation, it's an inflammation deep inside the body. We're going to talk about it a little bit later. It can lead to anxiety and depression because, when you are overweight, obese, people become anxious, they become a little bit depressed. So we need to address all those things. They can develop eating disorders, they can have a stroke, they can have a heart attack.
Yeah, in obesity, they get everything,
So,
yes.
and there is some evidence saying that if you are obese, especially morbidly obese, you can develop cancers.
Oh.
So you can have accidents while driving. You can fall and break a bone. So that's why if you look at what obesity does to you, then you realize that it's not an innocent diagnosis.
Oh.
It has real health implications.
So diabetes and obesity is not a...
You don't take it lightly.
Don't take it lightly, yes. And what about, we can, like obesity, lifestyle, and everything?
Yes, so the thing is, what do we do? Now we know the problem, right? We have seen the scope of the problem. So what can we do to help our patients, right? So, there are a lot of things, there are a lot of understanding of obesity, how it starts, how diabetes starts. So there's something called epigenetics, okay? So Here, the gene manufacturing that determines your health and your disease process. Okay, so this is the way, these are all the mechanics of epigenetics. There's something called DNA methylation, histone modification, microRNAs. So still developing science, but it looks like even when you're a small child, even when you're in the womb, right? If mama smokes, or if the mama is very obese, so that can cause prenatal stress, then lead to later childhood
The
obesity.
child will get that.
Obesity.
Okay.
Yes,
Oh.
right. So then the environmental factors, nowadays all this pollution, right? So there are some suggestions saying that concentrated fine particles in the diesel fumes, they can cause obesity.
Oh.
So there's something called endocrine disruptors,
Oh.
very tiny, tiny particles which we can't even see. It's already in our food, in our water. See?
Nobody realized that.
Nobody realizes
Nobody
that.
realized
so,
that.
So they can interfere with this gene transcription and cause obesity. And behavior, like lack of exercise, smoking, right? High-fat diet. And nowadays we talk about gut microbiome, gut health, right? So everything will contribute and disrupt this genetic manufacturing process. In essence, then that's the reason why you develop diabetes and obesity, insulin resistance, inflammation.
Correct.
So it's very interesting. There's a lot of
No, really, it
new
is
science
interesting
happening.
because many of the people, they were not aware about these things behind the screen.
Right.
So
Yes, sir.
now, how does the obesity affect the metabolism and hormones in
so-
the human body?
Yes.
What
So,
you-
yeah. So, obesity is, as I mentioned, it's a complex disease. And one of the problem is there is something called inflammation, which happens inside the body, in the blood vessels, at the endothelial cell layer. So, when you are very, very insulin resistant, let's say you eat a big steak meal, right? That causes a lot of inflammation in the body. So, a lot of bad, noxious agents, they flood the blood vessels. And the blood vessels, they have a mechanism where they can protect themselves. They have endothelial cells. You could imagine a cut end of the blood vessel, and it's lined by all these endothelial cells.
Inside.
Then when you eat bad food, when you have severe other metabolic disorders, you have a flux of all these noxious agents coming into the blood and bathing the endothelial cells. They're like hydrogen peroxide, nascent oxygen, oxygen-free radicals. So they're very noxious agents. They cause actually constriction of the blood vessels. But we need to keep the blood vessels patent. And how do they do that? Endothelial cells have something called nitric oxide. That's their defense mechanism. But the manufacturing of nitric oxide is very finite. It's not infinite.
Okay.
So if you keep on eating bad food 3 times a day, the body
Then it's
cannot
gone.
handle it.
Then it's
So that's why you develop endothelial dysfunction. That's the root cause of all the problems. From then you get atherosclerosis, you develop prediabetes, diabetes, cardiovascular disease.
Oh.
Right. And even in the fat cells, you could imagine a fat cell. Okay, let's say this is one normal fat cell. If you're healthy, the inside there are something called adipokines. There are good adipokines, there are bad adipokines. Let's say you make a person exercise, lose weight, then the good adipokines levels increases in that fat cell. For example, adiponectin, that's a good adipokine. We need higher levels of adiponectin. But if you become obese, super obese, and if you develop hypertension, diabetes, then the adiponectin levels go down.
Oh.
But if you make that person exercise, lose weight,
Then
you
it
see
will
the
go up.
adiponectin
Okay.
level go up. And the bad
down.
adipokines, such as TNF alpha, resistant, they all come down. So it's the same cell.
Same cell.
It's so smart. It's a very,
Really,
the body is
really it was
very
informative.
Yes.
Thank
So
you,
that's the thing,
thank you.
But then you develop prediabetes, diabetes, cardiovascular complications. So.
That's good. And what about the, we can talk about this metabolic
Yes.
syndromes in human body
yes.
or
That's very
patients?
important, because, the question is when a patient walks into your office, you want to see whether this person has metabolic syndrome or not, right? So let me try to move forward. Okay. So now how do we make a diagnosis of metabolic syndrome? Again, all you need is a tape measure and a blood pressure machine and one fasting lipid panel. Those three will help you to see whether a patient has a metabolic syndrome or not. For example, you use the tape measure, look at the waist circumference.
No.
In men, more than 40 inches, and women, more than 35 inches. Okay, that's one criteria. The second criteria is the blood pressure. If the blood pressure is more than 130 or 85, so that's another point.
Oh.
Then you do the fasting blood work and look at the glucose. If it's more than 100, that's another point. Then you look at the fasting lipid panel, and if the triglyceride is more than 150, there is another point.
Oh.
Then if the good cholesterol is low, HDL is the good cholesterol. If it's lower than 40 in men, lower than 50 in women, that's another point. So now there are like 5 points.
Oh.
And if you have 3 or more points, then you consider that patient has having metabolic syndrome.
Oh.
So there's a definition, there's a code that you can build. So easy, yeah. But,
So easy
but
to-
generally you can look at the patient. If you see an apple shape, yes, more than likely that they have a
So by
metabolic
seeing
syndrome.
only now you can
Yes, but you have to
identify
verify.
the person like.
Yes, but the thing, this is spot diagnosis, but you always verify. So,
So verify with this diagnosis, all
correct,
these things,
diagnostic tools.
blood,
Yes, it's
blood
easy.
pressure
It
and
takes-
everything.
It takes 5 minutes. So.
5 minutes. Yeah.
Yes.
And what are the like warnings you will talk about for the diabetes?
Yes, so that's very
People
important.
get the warnings.
Yes, so sometimes you don't even know that you have diabetes until somebody routinely does the blood work. They may say, oh, I'm feeling tired, I'm not doing well. They come home from work, they go to bed. No interest in life.
Correct.
So maybe they have diabetes. So, and usually increased thirst and urination, especially in younger kids who are developing type 1 diabetes, that's a classical manifestation. The mom notices that the child is not the same and irritable and goes to the bathroom 3-4 times in the middle of the night. Likely that's type 1 diabetes.
Type 1 diabetes.
Yes. In type 2s also, in the later stages, it can happen.
Okay.
So they feel more hungrier, they feel fatigued, vision blurry because the lens, the thickness goes up and down according to the blood sugar. And some of them can have neuropathy symptoms like a tingling and numbness in the hands and feet. Then they have a sore which doesn't heal. That's another pointer. Unexpected weight loss, dry mouth, itchy skin, and in women, recurrent yeast infection because there is a lot of sugar comes down in the urine. And some people will have nausea, vomiting. And sometimes when you look at the patient, there's something called acanthosis. If you look at the side of the neck, there will be a little bit velvety textured skin, little bit rough skin. That's called acanthosis. So that's the indication saying that they have a underlying insulin resistance, possibly pre-diabetes or diabetes. So, and some, like men, they can have sexual dysfunction. That's another way to
In
look
diabetes,
at. Yes,
okay.
yes, that's one of the causes. So,
So then we'll talk about the criteria for the diabetes, glucose criteria.
correct. It's all about numbers, right? We need numbers
Huh,
to say whether you're normal or not. So you can't say I'm normal or you're abnormal. We need numbers. So you can look at the fasting blood sugar, or you can look at the hemoglobin A1C. You don't have to fast for that. Or sometimes we do something called glucose tolerance test. We give you glucose solution to drink, then check your levels in 30 minutes and 1 hour and 2 hours. So if you have those pointers, you can make a diagnosis of diabetes. One of the easiest thing is get a hemoglobin A1C. Now the hemoglobin A1C is it's a sort of measure of your blood sugars in the last 3 months.
Okay.
A normal person will have a hemoglobin A1C of less than 5.6%.
Okay.
Then when you become pre-diabetic, the hemoglobin A1C starts climbing. So from 5.7 to 6.4, that's the pre-diabetes range.
Okay.
And once you hit 6.5 and above, then you're diabetic.
Diabetic patient.
Okay? Or you can look at the fasting plasma glucose. Normal blood sugar is less than 100, like 99 and less. When you have pre-diabetes, the sugar starts rising anywhere from 100 to 126. That's the pre-diabetes range. Once you cross 126, and if you demonstrate it at least twice, then we can classify you as having type 2 diabetes.
Oh.
Or you can do the glucose tolerance test, right?
Okay.
So a normal person, when I challenge you with glucose and check your levels in 2 hours, you will be below 139 because body is capable of handling that glucose load. It has enough insulin reserve. It will not allow your sugar to go more than 140.
Okay.
When you become pre-diabetic, the sugar, 2-hour sugar could be anywhere from 140 to 199. And more than 200, that means you're diabetic.
Oh.
So these are like very good numbers. Then the reliability, we can tell you whether you have diabetes or
Diabetes
not.
or not. Okay. Now, what are the treatment options for the obesity and
Yes.
the further?
Yeah, that's a very valid question, right? We know that the patients do certain things, but we cannot rely upon them all the time because they struggle. Right? It's not that they're bad patients. It's a real struggle to lose weight. So sometimes even with their best intention, with the best diet and the physical activity, still there are problems, right? So if you look at the BMI category, right? So in the first category, overweight, right? 25 to 26.9. So diet, physical activity, behavioral therapy, that's enough. You don't need any medications. But once the BMI goes about 27, then if you have additional risk factors like high blood pressure, high cholesterol, then you need to be more aggressive. Then you have to use medications, pharmacotherapy.
Correct.
And a stage will reach when your BMI is like 35, 40, then you have to do all these things, plus you may have to consider about bariatric surgery.
Oh.
So that's the last option, yes. But again, with the bariatric surgery, it's not like a sure deal because they all do well in the first 2 years. They lose about 100 pounds of weight.
After that, it
Slowly comes back because human mind,
Recurrence,
human nature.
reoccurrence, yes.
That's the biology. So
Okay. And what we can say, like after this, all these consequences and everything, diet and everything, what you will talk about?
correct, yeah. So that's always in a lot of talk. If you look at everybody's advertising about a weight loss diet, right?
Correct.
So there are certain simple rules. Diet is not something esoteric. It's a common sense diet. Okay, you don't have to spend thousands of dollars to have a diet.
Yes.
Okay, so if you look at this USDA Food and Nutrition Service, they have given some guidelines, some pictorial advice. You can go on the website and you can type in myplate.gov and it will give you all this information, healthier eating.
Oh.
And see, this is the food plate, right? What does it say? So see the white line in the center, then on the left of that or right of audience. So 50% of the plate should be fresh fruits and vegetables, all different kinds of greens.
Correct.
Okay. The other half should be for grains and protein. Protein means it could be fish, chicken, turkey.
Anything.
Right.
Anything.
Then grains, whole grains are much better. Then yogurt, you have to be careful, because all the dairy products, make sure that it's a low-fat, fat-free diet milk or yogurt. Okay. So yogurt is good because it has all this fermented stuff that's good for the gut bacteria. So we recommend yogurt, but you have to be careful of what you pick up.
Okay.
So as you can see, you have to plan your diet. Okay, that's what I tell my patients. When you wake up in the morning, first thing you have to decide, okay, I'm going to go to the supermarket. What am I going to buy? I tell them, write it down. And the other rule is, first eat before you go and buy your food in the supermarket. If you go hungry, you'll bring half the store back home with you because you're so hungry. You want to eat everything.
Yes.
So if you eat full, then go, then you do, and stick to the written
diet.
Yeah. Don't bring anything bad food inside the house.
Correct.
Those are some of the rules. And also when you go inside, you have to go around the store where there is a healthier food. Once you go inside, all the bad stuff. So,
All the bad.
Yes.
True.
yeah, so we're not going to talk. This is, if anybody wants this information, they can call us and we can give them. I
Yes.
can spend a couple of hours on these ones.
Definitely.
For the sake of time, we move forward. Okay?
Yes. And what about, we'll talk about the fasting, obesity,
Yes.
and diabetes.
Right, yeah. So this is a craze now, right? Everybody's doing intermittent fasting. It's pretty good, but you have to be a little bit careful. If you're diabetic and if you're doing intermittent fasting, I will tell them to be a little bit careful. For example, our American Diabetes Association, it doesn't recommend intermittent fasting because fasting is sometimes dangerous because you have all these diabetes medications, including insulin, hanging around, and if you don't eat for several hours, what happens? Your sugar will bottom out. This could be very dangerous. So. But people who are obese, not diabetic, probably they do better with the intermittent fasting, where you eat a meal very early in the evening, don't eat until next day lunchtime. The longer you go, the better. So the idea is if you don't eat, then your insulin levels will be very, very low. This is the hyperinsulinemia, which causes all the problems. So there are data showing that you can have a weight loss without actually losing the muscle mass. It can protect from obesity-associated chronic diseases, and it may improve glycemic control. It will bring down the insulin resistance, which is good. We have to bring down the insulin resistance, and it reduces the inflammation in the body. So at the same time, those are the risks. Sugars can go too low. They can have severe hypoglycemic reaction, have a seizure, have an accident. Right? You have to be careful. They can get dehydrated because they're not eating or drinking anything. Yes, make sure that they drink enough water.
Happen, yes.
And typically, some of them, they feel very tired. Okay, a little bit of low blood sugar, they feel tired. And they say, oh, I don't have any energy. So you have to watch out for all those things.
And then after all this, what are the activities for obesity?
Correct. There are some guidelines again. So basically what it is, I tell my patients to do 30 minutes of physical activity every day, at least 5 times a week. Okay, totaling 150 minutes a week. Then at least twice a week, you have to do some muscle building exercises like
some
dumbbells
weighting
or
and
some,
dumbbells and all
yes,
that. Weight exercise, okay.
Yes, you can do anything. You can walk, you can jog, you can dance, you can swim, you can play a basketball.
But some activities.
Yes, whatever that makes you happy.
Happy. Correct,
right?
correct.
So, so because exercises, it releases the endorphins in the body, right, in the brain. So you feel better when you exercise.
Correct.
And sharpen your focus, stress level goes down, and probably you sleep better after a good exercise in the evening, right?
Yes. Yes, absolutely. And what do you think about what are the FDA approved drugs? There must be some drugs which can be cured or help to avoid this obesity after diabetes and all that.
Right. Yeah. So today let's talk about some of the weight loss medications approved for chronic weight loss management, like FDA approved. See, the idea is, in some people do Adipex, phentermine, short term, you can't take it for a long time. So you lose weight, then when you stop it, you gain weight again. It's called yo-yo dieting. And research shows that yo-yo dieting is not good.
Not good.
So the idea is use one of these medications and use them over a longer period of time. Because you start the medication, you lose about 5 to 10% of your body weight, but then maintain those medication for several years. So that's the best strategy. There's no quick fix. There's no cure, right? So now these are all medications that we recommend for a chronic weight loss. So you have Orlistat, which is called Xenical, and there's a over-the-counter version called Ally. Then you have Qsymia, then you have Contrave, then you have Saxenda, then Wegovy. This is the latest craze now, so we are going to talk about it.
Okay.
So Orlistat, is a little bit a tricky medication because it reduces the fat absorption, and so more fat comes out in the urine, in the stools.
Okay.
So it's meant for people who are aged more than 12 years. Can't give it to younger children. So it works in the gut, reduces the amount of fat that is being absorbed, so that more fat is lost in the stool. But the side effect is you can have gaseousness, you can have diarrhea, you can have leakage of stools. Accidents can happen. So that's why it's a little bit tricky, especially if you're traveling and you're working in some big office. We recommend taking an extra set of clothes with you in case if you soil yourself. So then some warnings like rare cases of severe liver injury. And if you're taking cyclosporine, you're not supposed to take this medication. And make sure that take some vitamin pills because, the fat-soluble vitamins, they may not get absorbed. So you have to take some vitamin D and vitamin E. So the next one is a combination of phentermine and topiramate, which is Topamax. So this is called Qsymia.
Okay.
Again, it's a decent drug. You can expect to lose about 5% of your initial body weight. Insurance coverage is not that good. So, but the company gives it to everybody for about $100. They have to do some online thing about that. So, it has phentermine, which decreases the appetite, and topiramax, which reduces the craving.
Okay.
So Topamax is the medication that neurologists they use it for treatment of seizures and migraine headaches.
Okay.
So both of them in smaller doses looks like they are better tolerated and good with the weight loss. So, and some of the side effects like constipation, dizziness, dry mouth, taste changes, tingling in the hands and feet is very common.
Okay.
Trouble sleeping, so you have to be careful. So you can't take it if you have an overactive
So
thyroid
overdose
gland.
is also danger.
Yes. Or you don't want to overdose with these things. No. So that's why they have to stick to the dose. That's why when they start on a smaller dose for the first 2 weeks. Then there are 4 doses. You start with the first dose, second dose over a period of few months. So,
Okay.
we make sure that they come for regular follow-up so that we can
That is
keep an eye on
important.
their
That
blood
is
pressure,
important,
pulse, and lab work. So if you have a underlying coronary artery disease, previous history of stroke, you have to be careful. Especially if you have an abnormal heart rhythm. And we do not recommend in women who are getting pregnant. If you're pregnant, if you're on this medication, immediately stop. If you're taking this medication, if you're planning pregnancy, you stop.
Pregnancy, you have to stop.
You stop, then you start getting pregnant.
So in this pregnancy
Yes.
period,
Yes.
the 9 months, they cannot go for this. Okay.
Yes. So this is the next one. This is called Contrave. This is a combination of naltrexone and bupropion. Again, meant for people aged 18 and above. And naltrexone is the medication that we use for alcohol and drug dependence. And bupropion is an antidepressant. So both in smaller doses in combination, looks like you can lose about 5 to 8% of your body weight.
Okay.
So again, there are side effects, constipation, diarrhea, dizziness, dry mouth, headache, high blood pressure, tachycardia, insomnia, anxiety,
Okay.
depression, liver damage, nausea, vomiting. So that's why. So you have to keep an eye on the blood pressure. If you have a very high blood pressure, you should not take this medication. If you have a stiffened seizure, probably not a good medication. So, and you should not use any opioid pain medications, or you're withdrawing from one. You're not supposed to use these medications. And if you're already taking Wellbutrin and Zyban, you should not take this medication. So then you'll overdose with the Wellbutrin, right?
Okay.
So some people may even have suicidal thoughts. So we typically tell our patients' families to keep an eye.
Yeah.
Yes, because if they get depressed and if they start having suicidal ideation,
Then they take
either the patient
more
has to
intake.
call or family should inform us. So, rare,
So
but it's
very much
better to know all the
precaution,
side
yeah,
effects.
very
Not
much.
that it's going to happen to everybody, but
Yeah, but still you have to take care of
yes,
it.
yes.
So every
And,
medication has something.
Liraglutide. Now, liraglutide, this is Victoza, right? It's been in the market forever for the treatment of diabetes.
Okay.
FDA has approved liraglutide in higher doses for chronic weight loss management. So it's called Saxenda.
Okay.
So meant for people, older adults and children above the age of 12.
Okay.
So it's a GLP-1 analog. We're going to talk about this a little bit lower down the road. And common side effects are GI-related side effects. They feel full, constipation, sometimes diarrhea. Very rarely they can develop pancreatitis, which is inflammation of the pancreas. We don't know whether it directly causes pancreatitis, but looks like there is something to that.
is there.
So the problem is people who are obese, people who have significant visceral adiposity, people who are diabetic, the risk of developing pancreatitis goes up by 2 to 3 to 4-fold.
Oh.
So we really don't know by using GLP-1 analogs, are we increasing that risk? We don't know. What we tell the patients, if you develop any severe pain, epigastric pain, nausea, vomiting, stop the medication, call us, or if you can't reach us, go to the ER. That's safer. Because pancreatitis could be very dangerous. People can die of pancreatitis. Okay? So that's why Whenever we give medications to our patients, we talk about good aspects of the medication, but we need to tell them about bad things, what
Bad
could
things as
go
well,
wrong,
yes.
so that the moment they recognize that, they can stop the medication and minimize the damage.
Correct, correct.
That's very important. As a physicians, it's our job to educate patients
to
about the
educate
good
about
effects and bad effects at the same time. No point in glossing over, right? So,
Mm-hmm.
then this is the latest craze, right? Everybody wants to be on semaglutide molecules like Wegovy, right? So it's the same Ozempic molecule or Rybelsus molecule meant for people with diabetes. It's called semaglutide. FDA has approved semaglutide for chronic weight loss management, and the name of the drug is called Wegovy. So difficult to get it now because everybody's been using short supply. It takes a real effort to get these medications. So it's a weekly injection. It's called the GLP-1 analog.
Okay, once in a week.
Once a week, yes.
Okay.
And common side effects are just like Victoza or Saxenda, nausea, vomiting, abdominal pain, constipation. Constipation is very common.
Okay.
Diarrhea sometimes, feeling tired, sometimes frank vomiting. Then that's why we start smaller doses.
So every patient get this side effect? Or?
Not everybody. So
Not
these are all the known side effects.
Uh-huh.
Not that each person will get all the side effects.
Okay.
But we tell, okay, watch out for these things. But feeling full, bloating, constipation is pretty common.
Frequently,
And
if they find it this side effects, then they have to.
they will know, okay, my doctor told me, right?
Yes.
And most of the time, the side effects happen when you start the therapy, then they get used to it. Then when you go to the higher dose, some of those side effects can come back again briefly. So every time when we escalate the dose, some of these side effects can manifest again. So again, you should not use it with the other semaglutide containing products like Ozempic or Rybelsus, and don't use other weight loss medications like Qsymia and Contra when you're using this one.
Yes.
And again, warn them about possibility of developing pancreatitis. And in rats, these molecules caused medullary cancer of the thyroid. But we don't see that in human beings. But still, FDA wants us to keep an eye. We don't know.
Correct.
The prolonged procedures, whether exposure, whether they can develop a medullary cancer of the thyroid. Very rare. So.
In between,
So,
doctor,
yes.
one quick question in between just came in mind. Nowadays in market, there are many other therapies other than the doctor therapy. People, they believe in like social media marketing or everywhere now, everyone is marketing for the obesity.
Correct.
You want to lose the weight, you buy this, you buy that.
Correct.
And you eat this much and that much, then they get side effect. Then they come to the doctor.
Correct.
So what you will suggest for that?
Yes, so my suggestion to them is like, do your research, okay? Some people come and ask me, okay, should I use that? I don't have any experience with those things.
Yeah.
What I can tell you that what I know best, because these things, I work with my patients, and these are like, I see the results. I know the safety aspect. I know the beneficial aspect. When somebody does something on the internet, look at something and read, some people think that it's on the internet, it has to be true.
Yes.
Right? So my thing is don't, and they're very expensive therapies.
Yes.
With the
Very much,
questionable,
very much.
questionable benefit. But, if you use it, make sure that you don't break your bank and watch out for side effects. Anything happens, come to us, right? So I don't know. Some people do very well.
Because they wanted to make it faster.
Yes. So again, the Wegovy is called GLP-1 analog. So basically what it is, so the GLP-1 molecule that gets released from the L cells in the intestine goes to the pancreas and releases the insulin. At the same time, it goes to the brain and stimulates the satiety center. Then they feel full. Then it suppresses the glucose output in the liver overnight. And then it suppresses the glucagon. All these mechanism of action leads to better weight loss, better glycemic management. So these are one of the good medications in the market. And basically you start very slow, like 0.25 milligram once a week for 4 weeks. Then you go to 0.5 for another 4 weeks. then 1 milligram, then 1.7, 2.4. It's a process.
It's a process.
Yes, and watch out for side effects. If you're a diabetic person, make sure that if you are on other medication like insulin, sometimes you have to back off because these are like good medications that help you with the diabetes control also.
Correct.
That's why it's the same Ozempic molecule meant for people with diabetes, but the Wegovy is meant for people who are not diabetic, simply they're obese or obesity class 1, 2, 3, whatever. So
Yes. And what happens when you stop the management of this obesity and diabetes?
Yeah, that's a very valid question, right? Because remember, we talked about it. This is a lifestyle disease. It's a lifelong disease. So you can use all the things that you do, including pharmacotherapy, and you help them to lose weight, right? But some people say, I lost 20 pounds, 25, I'm very happy. I'm going to stop the medication. No, you cannot do that. Because remember, the insulin resistance is your lifelong friend or a foe. It's not going to go away. The moment you stop the medication, you go back where you started. So probably you can reduce the dose to a certain extent and maintain it for a long. The only time you stop is if you cannot afford it. Obviously, you can't get it, or the side effects are too much.
That time only.
Yes. So this is a very important slide. How these medications work, right? So especially recently, there is another medication came into the market called Mounjaro. It's not meant for weight loss, but it's meant for people with the type 2 diabetes. So it has two components. One is the GLP-1, just like Wegovy and Ozempic. And there's something called GIP-1. So it's called, it used to be called gastric inhibitory polypeptide, but nowadays it's called glucose-dependent insulinotropic polypeptide, something like that. So the combination, like if you look at the GIP molecule, so it comes from the K cells in the intestine. So it goes to the pancreas and releases insulin. But it also does something else, It works on the fat tissues, and actually it builds some extra fat, beneficial fat. Then it can go to the bone and help with the bone development. And it can go to the memory center and improve your memory. The same thing, the GLP, yes. So the GLP-1 portion, so that also it can increase your memory. But at the same time, it decreases your food intake because you feel full, right? So it brings, it releases more insulin from the pancreas. It suppresses the glucagon, which is a beneficial effect in diabetes. And it prevents something called beta cell apoptosis. Apoptosis means it's a pre-programmed cell death. Every day, few of the pancreatic cells, insulin-producing islet cells, they keep on dying. So this can prevent that. So the thing is, once you do that, you will have more beta cell volume. That means your body can produce more insulin and manage your diabetes better. So, and it delays the gastric emptying. That's why they feel full. Sometimes they get severe constipation. But the other advantage of all these GLP-1 molecules, the data shows that it can protect your heart. For example, Ozempic, Trulicity, they all have the data saying that if you use these medications in people with type 2 diabetes and underlying a lot of coronary atherosclerotic vascular disease, this will actually prevent heart attacks and strokes. So these are good medications. But the Mounjaro doesn't have that indication at the moment. But it's a good weight loss drug. So we talked about it. We are going to move forward. It's sort of like the same thing. So, it's been a wonderful conversation, right?
Really, it was. Now, Doctor, we'll take some questions which we have received from our audience. We can't take all questions, but a few of which I have got it here. So here is one Matthew calling from California, and he's asking, are there any alternative therapies such as acupuncture or massage that can be effective in managing these conditions?
I don't know. It's a speculation. You can do whatever you want, but my recommendation is, whatever you do, right, don't spend too much money. unless you know that it's going to work.
Oh.
But what Matthew has to do is reduce his caloric intake, keep the total calories less than 1,200 a day, reduce carbohydrate intake, eat more proteins, little bit of extra fat, exercise. And if you qualify, use one of these medications. This is a much better way of managing because it's much more scientific. So do I know anything about acupuncture? No, you should not ask me about the acupuncture right now.
No.
So, but if he wants to do it for something, good luck to him. So. But when you come to me, I know what to do with him. So.
Matthew, I hope you have received your answer.
Yeah.
And here is on Byron calling from Texas, and he has a question. Are there any drawbacks to relying solely on technology for the management of obesity and diabetes?
Oh, that's a very interesting question, right?
Yes.
Because we live in this age, this is a technological age. Everything is technology.
Yes.
We are all connected.
Nowadays, yes.
Just like brain cells. We are connected to each other. All our phones are connected, computers are connected.
Yes.
So technology, it has its good aspects and bad aspects. But we have to pick up a technology which is going to help us, right? For example, let's say you are going on a diet plan. Let's say you're diabetic. Then you can get one of these sensors, continuous glucose monitoring sensors.
Okay.
I like those because you need to know your numbers. Okay, you can use a Dexcom, wonderful sensor.
You get
You
every
can
day's
use a
numbers,
Freestyle Libre. You can use implanted Eversense. Use any sensors. Then you can experiment. You eat a meal. Let's say you go and eat a big steak meal. Then you can watch your number, glucose number, going up, right?
Yes.
So when it goes to 200, 250, you know that you did something wrong.
Yes. Yes.
On the other hand, you eat a healthy diet, and in 2 hours you're around like 140, 160, 180. You're good. So it's an educational tool, right? I always like technology. In fact, I strongly recommend, if you can afford it, if your insurance gives it to you, use one of these wearable technologies. It's good. Because what happens is, we all love technology, we all love numbers.
Oh.
And in the old days, we went by feeling, okay, you are a diabetic, but no way of knowing your sugar. You said, I felt good. I went to bed, I didn't wake up until morning, I'm good. That's good, actually. That's a good glycemic control. But now, no. Either you don't even have to do the finger sticks. You can use one of these wearable technologies and your numbers all the time.
Oh.
So I strongly recommend, at least intermittently, if you can't afford it all the time, you wear it for 10 days to 14 days intermittently and do all the bad stuff and see your numbers. So that will educate you.
Educate him.
Right. Okay. This is not moving. Can you move it for us? Okay.
Yes.
Yes, so this is the Health Well Safe. So I'm really thankful to Dr. Agrawal. He introduced me to this wonderful remote patient monitoring tool. It's helping a lot of my patients. So typically I have this app on my phone. Then we enroll our patients, and your team, you are the head of the program. So I forget that. So thank you. And I call you every now and then. So the idea is to enroll the patients, give them this Health Well Safe app. So the idea is they can upload all their data in that app, and then we remotely monitor their blood pressure, their finger sticks, and whatever you want to be monitored, right? Then your team does a good job, and I get notification every now and then saying that, okay, this patient has consistent low blood sugar or very high blood sugar. Then your team will help me to call the patient. We can do the video call using your app.
Yes.
And I can look at their readings. Nowadays, you did a wonderful job. You connected Dexcom G6 to the app.
Integrated, yes.
So, the other day I was talking to a patient on the video call, and I said, okay, I want to look at the Dexcom download. I don't have to go anywhere else. I can see it
Everything
on the
is ready.
How cool that one is.
Just
right?
pull up the app and you get everything.
Correct. Then not only that, you talk to the patient, you find out what's wrong, find out what medication they're on, and look at their glycemic control using the Dexcom. And now this patient was getting too much insulin at night time. So we told them to cut it down to from 20 units to 15.
See, you got the
Then
escalation.
we tell them, just to verify, we send them a text, right?
See.
Then the patient reads that, sends back saying that understood. See, now we are safe. Not only that, we have a record that we spoke to the patient, we gave the right advice, and patient accepted it.
So quickly. So
That-
quickly.
that's the
everything,
beauty. That's the beauty.
everything
So
on one platform.
Yeah, that's why I like your the whole Health Well Safe. This is our clinic hub, and all that red things, that alerts me that this patient needs attention, and we call the patient and take care of it.
Yes.
How cool it is.
Yes. We have some more questions, doctor.
Okay.
So
If
we'll
you
take
have
one
time.
by one. Yes.
Yes.
We have John here asking from Hawaii. What are the potential risk of using technology for the management of these conditions?
The risk is sometimes relying too much on technology, but not doing the right things, right? Money, some of these things are expensive. And sometimes the reliability, you don't know how, these are all developing technologies. When you see, let's say, a blood sugar of 63, with what certainty I can say that actually it's 63 compared to the actual blood sugar,
Oh,
right? We know that, these are like all these sensors. There's something called MARD. MARD is mean absolute relative difference. And nowadays, the lower the number is better. Now, if you look at the Dexcom and all, nowadays the MARD is like 7. It used to be 9, 10.
Oh.
So every year, the MARD, that means the reliability, the specificity, sensitivity improves with every upgrade, because technology advances. So these are very highly accurate, but sometimes, yes, there could be a problem.
There could be.
So if you see a blood sugar of 63, but if you feel good, then we recommend do a finger stick with using the older glucose meters. Just to verification purpose.
just to verify.
Yes. So.
Yeah, now next question is from Dawn from Georgia. She's asking, how does the use of wearable technology and smartphone apps contribute to the overall management of obesity and diabetes?
Right. For diabetes, it's easy, right? Because we know, right? You see a lot of patients. I use a lot of this technology. I use all these sensors. And I was the first in the country to insert implantable Eversense sensor. So the idea is, see, knowledge is power. So we have to give power to our patients. How do we do that? We give this technology so that they know their number.
Correct.
If they know their number, they behave better. Okay? Now some patients, they have so much work to do. They are like busy lifestyle running around. They don't have time to do the finger stick, give insulin and all. So nowadays we use all these smarter insulin pumps. Okay?
Yeah.
So these are the pumps like the newer versions of Omnipod, Omnipod 5. We have T-Slim pump. We have Medtronic 770G. They all talk to the pumps, to the sensors, and keep your sugar around 120 to 130 all the time.
Oh,
Okay.
Okay.
Now there's another patch pump called Vigo. Looks wonderful. Very simple. No electronic component. We love it. Then there's a newer pump coming into the market pretty soon. It's called Beta Bionics.
Okay.
So it's supposed to be something like your artificial pancreas.
Oh,
So that's going to come into the market, and it's you put the pump on, it will talk to the Dexcom sensor. Between the two, we keep on talking.
okay.
You don't have to do anything. It will keep on managing your sugar. All you have to do is when you eat, you have to press a button saying that I'm eating. That's it.
Amazing.
No carb counting, no looking at your numbers. Automatic pump. Just like
Automatic.
driving a Tesla car.
It's counting.
So that's why technology, I like technology. Even in obesity, so if you're exercising, of course, all these sensors are not meant for people with obesity unless you're diabetic. But, you can buy it online and use it while you're excising, see what happens to your numbers.
Numbers.
Right.
Correct,
Yes.
correct.
Yes, technology
It's
is good.
improving. It's improving. Day
Use
by
it.
day, it's improving.
Use it.
Yeah.
If it's available, if it's affordable, go ahead and use it. Because it will help you to train your mind. It's like a biological feedback.
Biological feedback.
Because when you do something and you see a bad outcome, you won't do that again. So,
You can control it, yes. Now we have another question. She's asking, Gwen from New Jersey, how do you help a type 1 diabetic teen who has obesity?
Right. So now, again, first priority is to maintain their blood sugar in a nice normal range. Then some of them, they have obesity. About 30% of type 1 diabetics, they are obese. So then again, you have to have individual plans like a dietary intervention, CDE intervention. Then you have to use some of these medications. So it's a process. So it needs a lot of attention. So.
Correct.
Yes.
Here I'll take the last question with us. Debra from Georgia, she's asking, she says, seems to have gained weight quickly and have become what my doctor considers obese after menopause.
Yes.
And she also says, my thyroid functions are off. Are these contributing factors to my obesity?
Okay. Both are valid questions. So what happens is when you reach menopause, right, you lose estrogen, right? And the biology has developed a plan to protect the bones because bones need estrogen to maintain their bone density. Okay. That's why women after menopause, they lose bone, develop osteopenia, osteoporosis. So the biology makes sure that women gain more fat and that fat cells secrete more estrogen to help the bone.
Correct.
So that's now women, unfortunately, they have to fight this biology. So, but again, the same principles come into play: eating healthy, reducing calories, exercising, and sometimes use this medication. Coming to the thyroid, that's very important because thyroid hormones, they maintain your basal metabolic rate.
Correct.
When you have underactive thyroid gland, your basal metabolic rate comes down, slows down, then you start gaining weight. So we want to make sure that the person is on right amount of thyroid medication and try to keep the TSH around 1.8, something like that. So you have to optimize, they have to work with their endocrinologist to optimize the thyroid hormone replacement so that weight also gets better.
Thank you, Dr. Baliga, for being with us and giving us such a wonderful guidance for your viewers watching here. Thank you, viewers. Stay connected with Health Well Safe. Please follow our channel, Health Well Safe, and our Facebook for a next webinar will be coming soon. Thanks for watching. Thank you. Thank you, Dr.
Santosh.
Baliga.
It's wonderful.
Thank you. It was a wonderful time and discussion.
Yes,
Thank you
appreciate
very
that.
much.
Okay, thank you for joining
Thank you.
us.
Thank you.
Thank you for joining our webinar. Be sure to follow us at Health Well Safe on all social media platforms so you can stay up to date with new healthcare technology. If you have any questions, please email us at info.healthwellsafe.com. And remember, your health is your greatest wealth, and we want to help you keep it safe.